And so these are my disclosures. You'll notice that I have some speakers bureau and honoraria and consulting fees from some pharmaceutical companies that might become relevant towards the end of the talk as I discuss anti-seizure medications, but other disclosures relate to royalties from a quantitative EEG textbook I wrote that have no relevance to this discussion. So the field of sleep and epilepsy is quite broad, and this is just a sampling of some potential topics from the American Epilepsy Society's Sleep and Epilepsy Work Group. We could be talking about clinical semiology and localization, using seizure states and patterns to help classify events. We could be talking about sleep as a differential diagnostic tool, apart from PNES. We could be talking about pharmacokinetics in terms of steady state timing of day and night with respect to anti-seizure medications. We could be talking about sleep quality in terms of disruption or alteration of sleep in epilepsy. We could be talking about clinical guidance of best anti-seizure medication practice or precision medicine. We could also be talking about basic mechanisms of using epilepsy as a means of evaluating epileptic alterations of sleep regulation. We could also be talking about preservation or degradation of cognition in face of sleep epilepsy interactions. We could also be talking about other comorbidities of sleep deprivation. And the list goes on. We could be talking about alterations of neurodevelopment with respect to sleep and epilepsy. We could be talking about SUDEP, mechanisms, detection, prevention. We could be talking about basic clock functions and using epilepsy as a ways to evaluate alterations of clock functioning. We could be talking about effects of sleep or chronobiology on hormonal regulation in epilepsy. We could be talking about maximizing seizure control through improving sleep or mitigating any proconvulsive effects of sleep in epilepsy. We could be talking about drug interactions with sleep aids, and we could also be talking about sleep monitoring devices in terms of warning systems and ambulatory sleep monitors. But what I want to talk about today are actually these three key objectives, which I think are must-knows in the middle of this very broad and fascinating field of sleep and epilepsy. So today I want to tackle understanding the shared neuroanatomy between sleep and epilepsy. I want to tackle the clinical effects of sleep on epilepsy, and I want to tackle epilepsy treatment opportunities using sleep. So I'm going to start with a shared neuroanatomy. And your first thought might be, oh my goodness, there's so much complexity here, sleep pathways, epilepsy pathways, there's going to be a lot of math. What is going on? This is overwhelming. Well, to simplify, the sharing is quite simple. You can't sleep without a brain, and you can't seize without a brain as a human. And so that is the shared neuroanatomy. To start, though, here's a typical adult hypnogram. So on the x-axis, we have the hours of a 7.5 hour sleep period with cycles through various sleep-wake stages as denoted by the y-axis through awake, REM sleep, non-REM 1, 2, and 3. And I'm going to tackle the neuroanatomy aspect of each sleep-wake stage as opposed to the epilepsy, as I think that would have been covered in other talks. So I'll focus on a neuroanatomy of each sleep-wake state. So starting with the neuroanatomy of wakefulness, this is governed mostly by the reticular activating system, or the RAS. Branch number 1 originates from the pedunculopontine and lateral dorsal tegmenta that then synapse forward to the reticular relay thalamic nuclei before projecting broadly throughout the cortex. Branch number 2 originates from the locus coeruleus, the dorsal median raphe nuclei, the periaqueductal gray, and the tuberomammillary nucleus, to then synapse forward to the lateral hypothalamus and the basal forebrain. You'll notice the lateral hypothalamus also is rich in orexinergic neurons, which then also influence the locus coeruleus, the raphe nuclei, the periaqueductal gray, and the tuberomammillary nucleus. If we think of the machinery behind what keeps us awake or generates wakefulness as an input, then recording from the cortex, the broad projections at the end of the pathway in the last slide, we have an EEG output. Now I'm demonstrating here a PSG, polysomnogram output, for two purposes. Number one, because the gold standard sleep scoring criteria are based on PSG as demarcated by the American Academy of Sleep Medicine. So this is the montage that's referred to. And number two, to also emphasize that on a PSG, there are differences between regular EEG interpretation for, say, epilepsy or in the ICU. For one, there's 3 times as much data over time. So here we have condensed material into a 30-second epoch. Also, there's limited spatial coverage. So in a way, this is low density EEG. So the first few channels on the slide here are frontocentral and occipital and temporal electrodes, select ones referenced to contralateral mastoid. So we have low density spatial EEG, but a higher density chronological coverage. There's also additional electrodes on this montage. We have additional muscle or myogenic EMG channels. There's also channels for airflow, channels for thoracoabdominal excursion, and channels for O2 saturation. But for the purposes of staging awake, this is defined by a posterior dominant rhythm that comprises more than 50% of the 30-second epoch. Now, if you're not one to have a PDR, which is normal, then you can also classify awake based on the presence of eye blinks, reading eye movements, irregular conjugate eye movements. On the chin EMG, this can show variable tone, but it in general is usually higher than what's found in sleep. Moving now from awake to non-REM, in general, the non-REM system is activated by non-REM on neurons, the majority of which are in the VLPO, the ventrolateral preoptic nucleus in the anterior hypothalamus. It is also accompanied by median preoptic nucleus influence, along with those in the basal forebrain and the nucleus solitarius, the parafacial zone in the medulla. Interestingly, there was reciprocal inhibition from these REM-on neurons with other structures I had mentioned in previous slides that pertain to awake. So in the posterior hypothalamus, that's where our tuberomammillary nucleus resides. In the lateral hypothalamus, those are rexinergic neurons that were implicated earlier on, the basal forebrain and the brainstem, the locus ceruleus, the dorsal raphe, and the mesopontine tegmentum. So I want to take a moment to emphasize this concept of reciprocal inhibition. So when non-REM is turned on, it will actively inhibit awake. And mathematically, this could be modeled through the Lotka-Volterra equations based on ecology, population ecology. So to use an example, let's say we have 2 populations. One is a group of bunnies, and bunnies being bunnies, they'll keep making more and more bunnies. And let's say that's awake. And we have now another population of wolves, and wolves eat bunnies. Let's say wolves are non-REM. Wolves will feast on the bunnies as the bunnies get more and more numerous over time, but at some point the wolves will go overboard and eat too many bunnies. The bunny population will crash, and so the wolves become predominant. So this is to switch from awake to non-REM. However, the wolves will run out of bunnies to eat, they'll starve, and that population will crash. But bunnies being crafty bunnies, at least a few will survive and they will reproduce. And so they will then become the predominant population. And in this way, it's a transition from non-REM into wake. And this ping-ponging, this reciprocal inhibition, really is a key principle in the neuroanatomy and functioning of sleep-wake regulation. And this here on this slide is just one example of that reciprocal inhibition between non-REM sleep and awake. That's an oversimplification, of course, because, for example, adenosine, another factor here, may modulate somnogenic effects of prolonged wakefulness. So being being awake for a long period of time can be reflected by increased adenosine levels as a measure of sleep debt, for example. So the outputs, just like awake, of the subcortical machinery can be captured on EEG. So stage N1 or non-REM 1 corresponds with late drowsiness or light non-REM sleep. For those with a PDR, it's defined by less than half of your 30-second epoch comprised of PDR. But with those who don't have a PDR, again, completely normal, there's diffuse theta slowing, vertex waves come to the fore, slow eye movements come to the fore as well. It's also been recognized that those without a PDR will have more N1 scored because artifactually there's more slow eye movements appearing before the PDR disappears. So this limitation is known. On the chin EMG channel, this can show variable EMG tone. However, it's usually lower than what's found in wakefulness. Moving forward to stage N2, this is now heralded by the presence or appearance of a K-complex or sleep spindle. A K complex is defined here as a biphasic negative sharp over the vertex or bifrontal regions lasting at least half a second. A spindle also lasts half a second, but it's a sinusoidal rhythm that's more central in location, and it's in the so-called sigma frequency between 11 and 16 hertz. V waves carried over from stage 1 can persist, and again, the chin or axial EMG tone is variable, but it's usually lower than what's found in awake. Moving even deeper now to stage 3 or N3 sleep, this used to be called stages 3 and 4 by the Reichschaffen and Kales criteria, but it was all lumped together physiologically, and it's now defined as any 30-second epoch that's comprised of more than 20% slow waves, so a fifth of the page. Slow waves here are defined as anywhere from half a hertz to 2 hertz. Amplitude is more than 75 microvolts over the frontocentral regions. Like stage N2, where vertex waves can persist, spindles can persist from stage N2 into stage N3. Eye movements are usually absent during this stage, and again, the chin axial EMG tone is even lower than what's found in awake, N1 and N2, and it can even approach the atonia that's seen in REM. Speaking of REM, here is the neuroanatomy of REM sleep from the McCarley-Hobson model. So the REM-on neurons, those which are responsible or most active during REM sleep, are again located in the pedunculopontine lateral dorsal tegmenta, and they're cholinergic in tone. They have rostral projections up to the reticular and relay thalamic nuclei before going broadly throughout the cortex, which will give an output of low voltage mixed frequency EEG, rapid eye movements, and they also affect hippocampal theta. There's additional caudal projections going south that affect spinal interneurons via the ventromedial medulla, and their end outputs are muscle atonia and autonomic changes. Now, again, invoking this key principle reciprocal inhibition, REM-on neurons will inhibit REM-off neurons and so on and so forth, with those REM-off neurons located in the locus coeruleus, which are noradrenergic in tone, the raphe nuclei, serotonergic in tone, and the turbomammillary nucleus, which are histaminergic in tone. You'll notice that a lot of the REM-on rostral effects mimic the RAS, branch number 1 of the awake system. And that's why the EEG output of REM also mimics wakefulness and can be quite difficult to disentangle. There are key differences, though, between REM and awake, and this has been followed a bit further through additional models like the Lou-Sapir model or the Loopy model, which have included additional neurotransmitters and additional neuronal bodies, for instance, GABAergic REM-on neurons in the sublateral dorsal nucleus of the preceruleus, GABAergic REM-off neurons in the deep midbrain, the ventral paraaqueductal gray, the lateral pontine tegmentum. Hippocampal theta has also been elucidated a bit further as glutamatergic in the preceruleus or the dorsal extension of the preceruleus, going to the medial septum. Even the caudal projections to REM atonia have also been refined to include both direct and indirect ascending glutamatergic influence from the ventral sublateral dorsal nucleus. Furthermore, in the Loopy model, there's additional glutamatergic influences for REM-on neurons from the sublateral dorsal nucleus and a hypothesized master switch invoking melanocyte concentrating hormone in the lateral hypothalamus in a similar region to where rexinergic neurons reside that will then inhibit the REM-off neurons in the ventrolateral paraaqueductal gray and the deep midbrain reticular nucleus. So there are key differences between REM and awake, and also an exquisitely choreographed functioning of different neuroanatomical substrates that govern sleep-wake regulation in terms of each sleep stage and wakefulness. The output, though, for REM after all of that can be quite tricky. Like I said, it could resemble wakefulness, but the scoring triad depends on the hallmark rapid eye movements. You have your low amplitude background of mixed frequencies. And if you're not one to have PDR, this can be quite misleading, can look like awake, but that's when the EMG can save you. Low chin EMG tone is a hallmark of REM. Now, sometimes there's phasic bursts of muscle tone during REM, which is normal, but in between those bursts, tonic EMG tone should be lowest out of all the states of vigilance. And interestingly, sawtooth waves and EEG phenomenon, not the EKG sawtooth, but EEG sawtooth waves can precede a phasic EMG burst. They're 2 to 5 hertz vertex negative potentials. And unlike the other stages of non-REM, where you have spindles carrying forward and K complexes carrying forward, none of that should carry forward into REM. It should be absent of these phenomena. So why am I harping on the neuroanatomy of wake and non-REM 1, 2, and 3 and REM? This is a talk about epilepsy, right? Well, the overall takeaway message is that in general, non-REM is a state of physiological hypersynchrony. And so that's reflected through thalamocortical oscillations like those spindles, those slow waves, and there's an increase in arousal threshold. Contrast that to REM, which is a state of physiological desynchrony, and especially phasic REM. I'm going to take a moment to clarify here. Phasic REM is not the same as phasic muscle tone in REM. So phasic muscle tone in REM is where you get a burst of muscle activity. Phasic REM is a sub-state of vigilance in which you already have rapid eye movements happening, and that is phasic REM. REM without the rapid eye movements happening is tonic REM. So during the phasic sub-state of vigilance REM, this is an especially desynchronized state associated with especially increased cholinergic tone. So if this is your background, your milieu, now you have the phenomenon of epilepsy superimposed. So this could be seizures, ictogenesis, epileptogenesis. Let's start with seizures. So seizures being defined as a paroxysm of neuronal hyperexcitability and or hypersynchrony, you can see how a hypersynchronous state would facilitate a phenomenon of hypersynchrony. Whereas if you have a desynchronous state, that would not facilitate a paroxysm of hypersynchrony. Now, in between seizures, if we think very simplistically and naively almost, let's say we have interictal discharges or interictal phenomena, the interictal state. If this state dynamically changes into a configuration that promotes seizure onset, progression, and then termination, this is the process of ictogenesis. And we can easily think of a scenario where the synchronous changes or desynchronous changes in non-REM and REM also affect ictogenesis, so even before epileptic phenomena become a seizure. This is different from epileptogenesis, which can be defined as a multifactorial process underlying the development and extension of brain tissue to generate spontaneous seizures. So numerous seizures does not necessarily equate to epileptogenesis. So non-REM and REM, while they have exquisite effects on seizures and ictogenesis, they may have an effect on epileptogenesis, but I want to simply emphasize here that there's three different concepts in discussing sleep stage in epilepsy. There's different sleep stages. There's also different considerations within epilepsy. Are we talking about the intersection with seizures when they happen? Are we talking about the intersection before they happen, the formation of the seizure, ictogenesis? Or are we talking about the long-term predisposition to unprovoked seizures, epileptogenesis? And this is what I want to go into now in the next part of the talk in terms of appreciating the clinical effects of sleep on epilepsy. So I'm going to recast that last diagram into this pyramid. Very simplistically, I think of epilepsy is the top of the pyramid in that you can have an epilepsy syndrome comprised of different seizure types. And so that brings us down to the next level of the pyramid, the individual seizures. And then the bottom of the pyramid could be conceived as interictal epileptiform activity or discharges. I want to focus first on the known clinical effects of sleep on ictal activity being seizures and interictal activity mostly represented as discharges. So starting first with focal seizures across asleep and awake, this is a meta-analysis of 1,990 seizures over 42 studies. And you can see that the fewest number of seizures, only 1%, occur out of REM sleep. In contrast, most other seizures happen in non-REM, and especially non-REM 2 here, with 44% of seizure counts. If we normalize now these seizure counts to rate, we come up with the bar graph on the left. So the ictal seizure rate normalizing REM to 1, relative to that, there's around 8 times more seizures in awake compared to REM, 88 times more non-REM 1, 68 times more focal seizures in non-REM 2, and 50 times more focal seizures in non-REM 3. Looking interictally, so discharge-wise, there's still an advantage of deactivation to REM, but not as much. So normalizing REM to 1, there's around 1.11 more times awake spikes. For convenience, let's call them spikes, even though it's not completely true. There's around 1.75 times more interictal discharging in non-REM 1, 1.69 in non-REM 2, and 2.5 times more in non-REM 3. This pattern seems to hold true for high-frequency oscillations as well. So here's a nice plot of spikes, ripples, and fast ripples over different states of vigilance, being W for wake, N1, N2 for non-REM 1 and 2, non-REM 3, and REM. And we see there's still a deactivating effect of REM and an activating effect of non-REM on HFOs. Moving now from focal epilepsies and focal seizures to generalized seizures, we have 256 patients over 9 studies in this meta-analysis, mostly driven by genetic generalized epilepsy. So for instance, absence. Here, it can be difficult to disentangle in a study what is interictal activity versus what is ictal based on the presence of clinical symptoms or the 10-second threshold. So for convenience, this was all lumped together. Again, using our normalizing trick of REM representing a rate of 1, there's around 3 times more seizures or generalized discharges in awake, non-REM 1, non-REM 2, and over 6.5 times in slow wave sleep or non-REM 3. Now, I've painted a tale so far of REM being deactivating and non-REM being activating across focal seizures, focal discharges, generalized seizures and discharges. However, this effect should be considered within the context of a single person. So in other words, there's inter-individual variability. So recasting the same data in the meta-analysis on the left in that pie chart, we have 3 studies where data was available for every single person and asking the question of, in what state of vigilance did this person with focal epilepsy have the most discharges? Again, most people had the greatest discharge rate in non-REM sleep, non-REM 3, over a third, but you'll notice that 11% of people had the most discharges in REM. So this is subject to inter-individual variability. The effect is not so pronounced in generalized epilepsy. Not a single person in those 3 studies had the peak discharging state in REM, but again, non-REM was confirmed again as an activating state, with non-REM 3 once more being the most activating in over half of individuals. And so if REM spikes persist, and in some people, they're actually the most frequent state, there is likely some prognostic significance behind how these spikes or discharges can overcome the typically deactivating effect of physiological desynchrony in REM against the ictogenic process or ictogenic process. And so this leads to the concept of the REM spike burden, where in this retrospective study, it was shown that every 1% more spiking or discharging in REM sleep on an epilepsy monitoring unit admission was associated with 1.7 more peak monthly seizures using a 4-year time window. So 2 years before admission and 2 years after admission, there would be about 1.7 more seizures per month during their peak seizure period. And so knowing now the clinical effects of sleep, different stages, N1, N2, N3, and awake, and REM on focal and generalized seizures, we can imbue our model earlier, that Venn diagram, with EEG findings. So in non-REM sleep, a situation of strong synchronization, there would be an expected reduction in seizure threshold. Wakefulness being sea level or neutral, mild desynchronization would be neutral. In REM, there would be stronger desynchronization, so an increase in seizure threshold. And we've discussed 2 dimensions, or there are 2 dimensions to this. We've already talked about one, and that is time. Up until this point, we've discussed the frequency of epileptic activity, but I want to move on to space. How does sleep intersect with the expression of these phenomena over brain space? So put simplistically, if you have a reduction in seizure threshold, you would expect many seizures over a larger brain space, especially for focal epilepsy. The opposite you would expect if there was an increase in your seizure threshold, there being fewer seizures over a smaller brain space. And so this expectation can be encapsulated in this schema here, where let's say we have an epileptic generator denoted by that burst, and then we have the spatial localizations as suggested by interictal discharges in sleep state 1 in blue and sleep state 2 in red. Now, in the example of where the generator overlaps with the blue, that's an instance of concordance where the sleep-wake stage could find a generator, and it demonstrated concordance with the generator. There's two other examples in this schema where the sleep-wake states may concur or disconcord with each other, but they're completely discordant with the generator. So this model, I think, is helpful in terms of letting us conceptualize the extent to which a sleep-wake state can localize the epileptic generator, and amongst themselves, how they can localize to the epileptic generator as well. And I bring this schema up because there's been a meta-analysis done as well, asking the question of, compared to a clinical seizure onset zone, so compared to after a very thorough pre-surgical evaluation and a surgical conference with a consensus, to what extent do interictal discharges from different sleep-wake states localize to this clinically posited seizure onset zone? And in 91 patients across 5 studies, the REM interictal epileptiform discharges were the most concordant, up to 85%, compared to non-REM, which was over 55%, and awake at 70%. Now, it's interesting further because over 5 studies where data were available, the REM interictal discharges were able to activate unique spatial coordinates and source localization analysis that no other sleep-wake state could find. And what's even more interesting is if you put your money where your mouth is, so we're not talking about clinical hypotheses or a surgical consensus where there's a lot of robust and interesting discussion, but this is now arbitrated by surgery. So someone has gone ahead, made the decision, we're going to resect in this area. Well, in this meta-analysis, 27 of 46 patients achieved seizure freedom postoperatively, and working backwards to where each sleep-wake state had localized the focus to, you'll notice that REM was mostly correct 84% of the time. When it was correct, at least another sleep-wake state was correct. However, 20% of the time, it was correct alone. And what's even more interesting is 0% of the time, it was uniquely incorrect. Where it was incorrect, it was accompanied by another sleep-wake state for 7% of the time, and at least 2 sleep-wake states 9% of the time. So again, clues that there's a unique localizing value in REM that might be related to its unique physiology and its impact on epilepsy, keeping in mind all the limitations of this being a meta-analysis and retrospective review subject to all sorts of bias. So that was a quick summary of the effects of different sleep stages on different types of seizures and interictal activity. I want to tackle now the top of the pyramid, the effects of sleep on epileptic syndromes. And this is getting at sleep-related epilepsies. So sleep can affect any epilepsy. It can activate, it can deactivate. What sleep-related epilepsies usually refers to are when you have seizures only in sleep or predominantly in sleep. Only in sleep comprises a minority of all epilepsy, around 10 to 15%. So 1 in 10, 1 in 9, 1 in 8, etc. And 80% of these are focal epilepsies, the majority of which are located in the frontal lobe, more so than occipital, parietal, or temporal. And there are classic examples, which are typically cited in this family, like childhood epilepsy with central temporal spikes or SECTs, Paniatopoulos syndrome, self-limiting late onset occipital epilepsy used to be called Gastaut syndrome, and in adults, sleep-related hypermotor epilepsy, now known as SHE. And here's an example of the common ones, and you'll see in the first 2 columns, those are some that I've discussed already, which are sleep-related. or sleep accentuated. There's also others which are awakening related. So the termination of sleep can also exquisitely impact epileptic phenomena. And examples of this would be JME or epilepsy with grand mal seizures on awakening. Now, I want to emphasize that even in the classic adult syndrome of SHE, even though most seizures happen in sleep, they don't have to stay like that over time. So this Italian study looked at 165 SHE patients, and they found that over 27 years, only half of them retained their seizure occurrence in sleep exclusively. Otherwise, most people shifted. They went from sleep only and then intruded into awake. There was an interesting minority of people, up to 2%, who had a mixture of sleep and awake, but then who shifted only into sleep. So the purposes of this is to illustrate that when I say a sleep-related epilepsy, I don't mean sleep exclusive. It's sleep as a predominating factor, sleep as a major influence, but it's not necessarily exclusive, especially over one's lifetime. And other examples of epileptic syndromes in which sleep plays a predominant role would be in hypsarrhythmia, epileptic spasms. And here's an example here from the turn of the century, where in panel A, we have non-REM spikes, which are higher in amplitude and more extensively distributed, which melt away in panel B during REM. There are fewer spikes located over smaller brain space. And notice the EMG channel at the bottom shows atonia. There is the lowest muscle tone, except for that little blip, that single phasic burst, phasic EMG, not phasic REM, the state of vigilance. So other epileptic encephalopathies where this dramatic difference between different sleep states occurs is also ESES, CSWS, and LKS. Now, moving from the genetic or developmental epileptic encephalopathies, sleep also can play a role in acquired epilepsy syndromes as well. So here's an example of a patient with anti-NMDA receptor encephalitis who presented with extreme delta brushes on the left. Early on in her course, this young female had retained sleep-wake cycling. And so on the right, during REM sleep, where we can see the rapid eye movements confounding the anterior channels, along with a noticeable absence of EMG tone through all the EEG channels and a sort of bland, low amplitude, mixed frequency EEG, there was an absence of extreme delta brushes. And so it appears that REM can impair extreme delta brush expression in anti-NMDA receptor encephalitis, thereby implying that sleep can have a profound impact on epileptic syndromes, also seen in the critically ill or acutely unwell settings. And so knowing sort of the landscape or the lay of the land for how sleep, different stages thereof, can affect different epilepsies in terms of syndromes, seizures, and discharges, and their localizations and so on, I now want to move to the last part of the talk, which is recognizing epilepsy treatment opportunities using sleep. So the most common sleep disorder is sleep disordered breathing, and the most common of that is obstructive sleep apnea. And not surprisingly, obstructive sleep apnea is common in epilepsy. Well, you might ask, is that just because, OSA is very common overall? I mean, OSA is around 1 in 10 of all adults up to will have sleep disordered breathing, and so is it just a reflection of that? Well, this meta-analysis in 2017 looked at a whole collection of studies, admittedly heterogeneous studies, but they came up with an estimated prevalence of 33.4%. That was as low as 20% or as high as 46%. So if you can imagine, half of all people, half of all adults, I should say, with epilepsy have OSA, there is an increased predisposition to having OSA if you have epilepsy as compared to the general population, this meta-analysis would imply. And so in addition to its commonness or its prevalence, this could also represent a treatment opportunity in terms of not only improving one's sleep, but perhaps improving one's epilepsy through improving one's sleep in terms of the breathing that happens in that state of consciousness. And this same meta-analysis then went on to look at what is the effect of treating OSA with continuous positive airway pressure, or CPAP, on seizure frequency. So there were three main categories in their outcome metrics here. I'll direct your attention to the first unshaded row, which is the 50% responder rate. So in 2014, there was a study done in Cleveland Clinic where they measured the 50% responder rate in epilepsy patients who underwent CPAP and no CPAP in their OSA treatment. And then in 2008, there was a prospective randomized pilot trial out of Vanderbilt asking the same question. And even though the result was not significant in this meta-analysis, there was a trend towards an increased 50% responder rate, a higher odds ratio of having 50% reduction in seizures treating with CPAP compared to not treating with CPAP. What I will direct your attention now to, though, is the shaded row, which is looking at arguably a higher, more rigorous metric, 100% responder rate, in other words, seizure freedom. And here the meta-analysis found that there was statistical significance in terms of that study from from Vanderbilt, and another study out of Boston Children's in 2011, where they found treating persons with OSA and epilepsy with CPAP gave you a higher odds ratio of being seizure-free than if you did not do so. Granted, the follow-up periods were heterogeneous here. They were up to 10 weeks in the randomized trial in 2008, but up to 1 year in 2011. So again, this is suggestive here that treating OSA with CPAP can improve seizures. And in the meta-analysis, lumped together all of the outcomes into one global odds ratio of 5.26. And that ranges as low as 2 times the odds and up into 13.5 times the odds. And then lumping things together, arguably a heterogeneous move, was statistically significant here. So I want to switch gears now from obstructive sleep apnea to anti-seizure medications. So remember those disclosures at the beginning there. But into 2013, this was the lay of the land in terms of sleep parameters and anti-seizure medications with appreciable levels of evidence behind them on how they would affect parameters like sleep latency, so how long it would take for you to fall asleep, the prevalence of arousals, the duration of non-REM 2, non-REM 3, REM, and sleep efficiency. So sleep efficiency, very briefly, is the time in bed spent asleep. So in theory, if you went to bed, but you couldn't get a single second of sleep because you were so wired for 8 hours, that'd be sleep efficiency of 0%. And so looking here on the y-axis of all the drugs that were studied in this meta-analysis, we have benzos, barbiturates, phenobarbital, phenytoin, both acute and chronic, carbamazepine, single dose or chronic, valproate, felbamate, lamotrigine as add-on, levetiracetam, zonisamide as add-on, topiramate, gabapentin, mono, gabapentin as add-on, pregabalin, tiagabine, ethosuximide, vigabatrin. We see it's a mixed bag. There is no so-called ideal anti-seizure medication that would improve or be neutral to all of these parameters. A more recent meta-analysis from 2021 bridged the gap from 2013 to 2021. And over the past 8 years, we've now been afforded the luxury of subdividing older and newer anti-seizure medications. So focusing on the older ones, there's evidence for carbamazepine, clonazepam, phenobarb, valproic acid. And here the sleep parameters are a little bit different. So again, on the x-axis, we have sleep efficiency, total sleep time, sleep latency, WASO, which is wake after sleep onset, or in other words, how much time you spent awake after you had fallen asleep. Related to that are arousals and awake in the next column, N1, N2, N3, and REM. The PSQI is the Pittsburgh Sleep Quality Index. So in other words, what your sleep quality rating was subjectively. The ESS is the Epworth Sleepiness Scale, SSS is the Stanford Sleepiness Scale, and insomnia. So even with these expanded parameters and with more studies over the past 8 years, again, it's a mixed bag in terms of how the anti-seizure medications can affect these sleep parameters. Focusing now on the newer anti-seizure medications, on the y-axis, we have cannabidiol, eslicarbazepine, another felbamate study, lacosamide, lamotrigine, levetiracetam, oxcarbazepine, and perampanel. So it seems to be a mixed bag again. However, the authors of this meta-analysis did emphasize 3 medications that admittedly there could be fewer studies than the older ones, given that they haven't been around for as long. And all it takes is for a new study to show a negative or a bad effect on sleep for this entire calculus to change. But at the time of this meta-analysis publication, it looked like eslicarbazepine was not that offensive to sleep. So in the Romidi study, nothing was affected. So take that for what it's worth. In the Pellegrino study, there was a reduction in excessive daytime somnolence. So again, the authors suggest that, given that this is such a murky field with so many medications, so many parameters, so many different study designs, it's so heterogeneous that eslicarbazepine could be not offensive to sleep. So in other words, an anti-seizure medication that's theoretically neutral or even beneficial to sleep. Same reasoning with lacosamide. So the Foldberry-Schaefer paper from Cleveland Clinic showed there was a reduction in arousals with lacosamide. A paper by Hudson earlier on showed an increase in slow wave sleep. So again, the meta-analysis authors thought, well, it's not shown to be offensive. There are some improvements. And so perhaps if someone has excessive daytime somnolence, maybe you could consider lacosamide. Again, keep in mind that the evidence is class 4 for the Hudson trial. So again, we're looking at what is least bad. Looking at perampanel, here there's a few more studies, but it's the same rationale. So in the Rocamora study, they seem to show a lot of nice things, more sleep efficiency, more sleep time, decreased deep latency, decreased WASO, decreased arousals, more slow wave sleep. In the Lee study, there was decreased insomnia measures. And the Toledo study, there was a reduction in the PSQI score, so better sleep quality in the first 3 months, which didn't hold true in the next 3 months, though. And then interestingly, the opposite happened with the Epworth Sleepiness Scale, in that there was no change in the first 3 months, but a change in the latter 3 months with the 6-month mark. So again, the meta-analysis authors speculate that perampanel might be okay or preferred if there's insomnia, and there could be some chronotherapeutic rationale to this too, along with eslicarbazepine, given that they're both dosed once a day. So perhaps you could give it at night to selectively affect sleep in some positive way. So what I'm trying to convey here is that in terms of finding a magic bullet, an anti-seizure medication that is beneficial to sleep, that is exceedingly difficult. And it really depends on the individual person. And it also depends on, at least more realistically, aiming at probably a lower benchmark of looking at what is not offensive or neutral to sleep, let alone looking at what's beneficial to sleep at this time. And so those are the 3 learning objectives I want to cover today. So again, there were a million different potential topics on sleep and epilepsy, but what I want to emphasize was that there's a shared neuroanatomy between sleep and epilepsy. So understanding the first principles of where sleep and wake are generated within the brain to the extent that it's known, and there's a lot left to be discovered, but that can help predict the interaction with epilepsy based on neuroanatomical principles. And then from there, we can reconcile it with known observations of how sleep affects epilepsy in the literature based on the different sleep-wake state, be it REM, specific non-REM state, or awake, and in terms of the epilepsy type. So is it a focal epilepsy? Is it generalized? Are we talking about seizure generation, epileptogenesis, interictal discharges? And then last but not least, realize that this increasing knowledge, both from first neuroanatomical principles to lessons in the clinic at the bedside, this is going to allow further refinement and advancement of epilepsy treatment opportunities that will hopefully allow us to break out of this paradigm, a paradigm where there are more and more seizure medications, but typically there is a ceiling that is hit in terms of efficacy. And so if there's a new way to synergistically tackle 2 problems, sleep and seizures, with a treatment strategy, I think that would be much welcome from the field. So until that happens, there are two potential avenues that come to mind: treating obstructive sleep apnea and choosing an anti-seizure medication. The data are not fully clear, they're not fully concrete, but it is a moving target, and it's important to be aware of the data behind the moving targets and to be prepared for the time when a definitive recommendation can be made in the form of a practice parameter or guideline in the future. So I think I am under 45 minutes. I'd like to thank everyone for your attention. I'm happy to take any questions.
Marcus, thank you. That was an excellent talk, fascinating, and I learned so much from you today, and I'm sure we all did. We have some questions that are popping up in the chat here, but thank you for highlighting the importance of REM sleep and the assessment of interictal discharges. To get the ball rolling, are you suggesting that we should look at the location of interictal spikes during REM versus non-REM sleep when working out the irritative zone for surgical workups? Is that common practice, or is that something we should be doing more?
Yeah, that's a wonderful question. I'm not sure how common practice it is. It seems to be more of a research question right now, but what literature is available on the subject suggests that it might have some additional localizing value. And I mean, REM spikes are difficult to find in the first place, given that they are rare, but when you do see them, you might as well take the time to appreciate its spatial location, because it might show new insights that could be helpful for pre-surgical conference.
Great, thank you. And then Sudhir Kitapal is saying, can interictal discharges in EEG predict seizures that will only occur in sleep? Is there a specific pattern or waveform that can help us to know that, or not yet?
Wow, that sounds like a PhD project in the making. I would say that there's nothing definitive. I mean, I guess you could surmise that, you know, there could be paroxysmal fast activity that's seen more with tonic seizures in sleep, but these are associations. There's nothing pathognomonic. There's no magic biomarker that will allow someone to say, oh, I saw the let's call it the Jones marker, and therefore I know this person will have a seizure during sleep.
Yeah, I think that you're right. That's another PhD project for someone to discover in the future. Javier Ortiz is asking us about your opinion of the relationship between poor quality of sleep and epileptogenicity in epilepsies. I think it's a circular question, but how do you think the two relate? Does the one make the other worse?
You know, without any definitive evidence, I would say yes, it just makes intuitive sense. I mean, it's a lot easier to study the seizure question because sleep and wake cycle, whether you like it or not, every 24 hours. And so it's easy to, well, relatively easy, I should say, to get data on the milieu of in a sleep state on seizure formation. But epilepsy formation, that's a much higher bar. And I think, you know, even for models of epileptogenesis in animal studies, we're looking at TBI type paradigms, and we have to replicate the epileptogenic process. So, you know, I'm not aware of any TBI paradigms that have looked at REM sleep or non-REM sleep in particular, but even in the absence of that, it makes intuitive sense that poor sleep over time, you know, if it plays such a critical role in neurodevelopment of children, I don't see how it wouldn't play a role in the formation of epilepsy. So I think intuitively there must be a relationship. I just don't have data to back that up.
Yeah, thank you. It's always challenging getting pure data to prove these concepts that we seem so intuitive. Moving along next, we're talking a little bit about different medications. So clobazam, its effect on sleep, and also cannabidiol or CBD oil. How do they affect